So I'm Scott Leckie, and I run the seminar series. And my pleasure today to introduce Rohloff, who is a professor of medicine in the Division of Global Health Equity at the Brigham and here at HMS. He received MD and PhD in pathobiology at the University of Urbana Champaign before completing his residency in internal medicine at Brigham. And he's done both diverse work since then in Guatemala, where he's worked to ensure provision of care to its rural population. He's the founder and chief medical officer in Guatemala of Maya Health Alliance. Non-communicable chronic diseases and hosting 50,000 visits per year. Peter is an expert in the management of pediatric growth disorders, especially chronic child malnutrition, and has developed and validated protocols for this disorder that are used by clinicians and health promoters of Guatemala. Okay, interdisciplinary perspective to the issues he's considered. And this all came through the intercession of Aaron Shackhouse, initiative on healing humanity. Likely had global health concerns from multiple mutually informing standpoints. So we'll be making such cross-disciplinary approaches in this talk today on holistic perspectives on child growth and nutrition, insights gleaned from demography, anthropology, and clinical practice. And let's start.
Thank you, Scott. Hope not too disappointing. It's definitely brown baggy. We'll see. I want to thank Aaron in particular for pushing me on some. Some of you know that I talk about stunting all the time, and so this is my attempt to think stunting a little bit more holistically, and bring in some literature from fields other than medicine. So we'll see how it goes. I am prohibited from using the computer. I should remember I'm going to do this, he said. I've been working in Guatemala for a long time, and I've been thinking about some sort of big topics in my own practice for a long time. And I think this is a sort of background for this talk, and then this plus Aaron's push to be a little bit more holistic and synthetic in my thinking. But I'm really interested in how, sort of when we do development, and especially in child growth and nutrition, this is really fundamental. Child growth and nutrition in global health is so focused on technical objects and technical products, like what supplement food are we feeding children now, what ruler or anthropometric index are we using to define progress. Like it's so almost magically focused on whatever the piece of technology or current food product that we're showing is. And so I've always sort of been really conscious of this. I felt a little caught up in it and dispowered by it. And so I'm going to try to talk about some of that here today. And nutrition in particular, scientific concepts have the same sort of fate. They take on a life of their own. They become very unexamined critically. Folks in nutrition practice lose sight of edging and forgetting and compromises that go into the run-up to a new scientific consensus, and sort of takes on this life of its own. And we forget the assumptions that we made when we make a policy or the consensus statement. And it's been especially acute in the last few years as I've increasingly been training a lot of practitioners, including nutritionists, the emergence of this sort of first 1,000 days of life concept in early child nutrition. Children has to be focused in pregnancy and in the first 2 years of life. Otherwise, there's no point and it's useless. That's a negative way of spending the 1,000 days of life. But this has been sort of in the last 3 or 4 years, this has been the thing in child nutrition. And it's problematic for reasons that I sort of hope to explore with you all a little bit today. And this is really sort of a personal, professional practice development goal. Can I be more thoughtful in my own practice? Can I incorporate data history, data from other disciplines, so that myself and my trainer are more thoughtful and more humble, as we are working with children. That's why this is sort of brown baggy, because this is sort of my attempt to do this, and I hope to get some feedback from you. And I'm going to talk about stunting today, but I think that this kind of approach is probably useful as we are working with trainees and working to improve our own practice around the world. So, Oh, that's the wrong computer. So I see. My notes are in this computer, and so this is a picture of me in a market with a phone filling this magical, mystical peanut butter paste produced by a French privately held company that solves all nutrition problems around the world, right? And it's not really that different, both in terms of posture and my position in this community. This guy who's showing magical eucalyptus balm that heals cervical cancer, urinary tract infections, prostatic hypertrophy, gastritis, and diarrhea. Right? You eat it or rub it on your skin. So it's sort of like, again, just who are we and why are we so using our social and cultural capital to sense these products or bend these scientific concepts and be a little bit more potentially critical about how we're positioning ourselves with respect to that. So stunting. So for those of you who don't know what stunting is, this is the second introduction to stunting. Stunting is the most common pediatric growth disorder in the world. About 150 million children under the age of 5. It's essentially a disorder in which children have relatively normal weight, at least when adjusted for length, but that they have pretty remarkable faltering their growth, their height velocity, especially after the first 6 or 8 months of life, which is essentially when the transition to complementary feeding is supposed to occur. So when children are supposed to be transitioning from exclusive breastfeeding toward eating foods, solid foods, lots of things can go on, including that they can suddenly be exposed to a whole broad range of new waterborne or foodborne pathogens. They start to get all of the usual intercurrent acute febrile illnesses that are common in the first years of life, and there may not be food, or food may be prepared inappropriately, or all of the things that happen. So it's really a nice disease entity that acts sort of an integral function for all of the things that can differentially affect the thriving of young children, whether it's food policy or food insecurity, or lack of access to medications or water infrastructure, or who are empowered and have the skills that they need to raise their children. This is what stunting looks like. This is just the growth curve here. This is just a child pulled out of my EMR. You can see that this child is blue 0 Z-scores, so right at the population. You can see that this child actually has basically a totally normal weight, but then you can see that when the child is born, something happens around 9 months and you start to lose velocity, so that by the time the child is about 1.5 old, they're sort of in the -3.5, -4 standard deviations range below the population reference for age or length for age. It continues forever, essentially, although that's one of the things I want to dispute a little bit here today with you. But in theory, classically, this loss of height is then lasts into adulthood. So this stunting is. Show you this interesting graphic. This is from this really fantastic website, which I recommend to all of you highly, NCD Risk Factor Collaboration. They actually published this paper in ELEC recently, but they have this really awesome interactive website where you can produce all sorts of cool graphs. And this is an E96 cohort of adult height around the world, showing mean adult heights, not adjusted by gender, just mean adult heights for different countries in the world. And what you can see here is that, adult height has always had remarkable variation, regional and country-specific variation, going back really as long as we can remember. We don't really have anthropometric data on adult populations before, other than bones, like bone data from archaeological sites. We don't really have anthropometric data on adult or child populations before about 1750, which is when the first studies start to come out in England and France. So going back at least that long, and then increasingly in the 19th century, the data just becomes very, very rich and very robust. And so you can start to sort of construct things like this. And so you can see that mean adult height is quite a bit higher, say in Northern Europe, in Canada, the United States, at the turn of the 19th century, into the 20th century. And then see that there are pockets of very, very short populations. For example, down here, South Asia, and this very dark red spot here is Guatemala. It's all been the population, the country in the world with the shortest adult population, going to the 1800s, and continues to be the population in the world, the shortest adults up to the present day. Also Peru, Bolivia. One of the things that you might sort of conjecture from this kind of graph, at least this is not obviously universally the case, but certainly some of these places where populations are very, very short are populations where most of the population was indigenous. So these would be down here, this would be Maya here, and so these would be places where there's a high degree of the indigenous population. And so sort of inexorably, it's not surprising that a lot of this variation in height was blamed on race. And actually it continues to the present, blamed in large part on race. And a lot of folks who studied variations in adult population in the 1800s and in the early 1900s would said and did say these were inherent biological genetic differences in really distinct populations of human beings, right? And so that's interesting, and I think we all know that. But sort of because of the fixation on race in medicine and public health in the 1800s, there was a little critical examination at the time of colonial policy or social disparities in health and these sorts of things. And that's a long time coming around. And one of my points, one of the things I've been learning over the years about studying is that actually took such a long time to come around that as recently as 10 years ago, we were still mostly talking about race when we talked about child growth, which is absolutely remarkable, and one that I want to try to understand better, with you guys here a little bit today. So this stuff, right? I mean, this is obviously an extreme example that I just sort of pulled for shock. But at the time that these early anthropology were coming out about adult height and growth, this is the same time when folks were measuring the insides of the skull and determining that white Europeans had the largest brain, making cases for differences in racially based intellectual potential and cognitive outcomes of these sorts of things. And of course, Morton is a famous North American example of this, who has this really detailed and beautifully illustrated, I must say, a collection of skulls from all of North and South America, including lots of indigenous populations in North and South America. And you can download this entire book from some website if it's interesting to you. So our understanding of height was at the time and up until just a few decades ago was as egregiously racist as it had some of those features to it, as I'll explore with you here. And I'm sort of interested in why suddenly in the last 10 or 15 years, we've sort of stopped talking about height in racially charged ways. What that transition was. I know the answer, but I'm interested to hear what you think. So, I was working in Guatemala about 15 years ago. It was pretty common for Guatemalan physicians to say, no somos desnutridos, somos chapinis. We're not malnourished, we're just Guatemalan. Very commonly framed. And in fact, the racial justification for shortness, right? Guatemalans aren't short, they're just Guatemalan. It's just who we are, we're just Guatemalan. If we weren't Guatemalan, we wouldn't be short. And it's remarkable to me that this was the prevailing philosophy of child growth and the prevailing perspective on the potential of adult populations to reach height potential in Guatemala and really everywhere else in the world as recently as 10 years ago. So what was that? Why was it that all of us thought that shortness was genetically, biologically determined as recently as a decade ago? And this really only changed with the publication of the World Health Organization's growth cohort study, which I'll talk about here in a few seconds. like I said, I think that there's this element, this vestige of racism or biological racism in our public health practices in many places in the world. And this has its egregious manifestations, like measuring the size of human and make postulates about race-determined differences in brain size. But sort of like argument has persisted in an unexamined and unreflective way all the way up to the present day, at least in the study of growth, human growth. So, and it's also sort of like a cute kind of racism, like it's a point of pride, like we're not short, we're just Guatemalan. Like it's almost sort of nationalistic racism. We get to be short because we're Guatemalan, sort of part of who our identity is. And so then all of the calls over the last, from about 1950 to about 2000, all of these efforts by many ministries of health around the world to develop local norms for child growth could be seen in some ways as sort of playing into that idea of local norms can almost be read as code for sort of racial theories of height, in places like Guatemala. And can also be seen as a way of, and I think not intentionally and not explicitly, but can be seen as a way of deferring the inevitable, much more difficult conversation about social determinants of height and social determinants of growth in children. Because if children are just short because they're Indian, you have to think about the fact that they might actually be short for other reasons, like not having health care or not having food. And so it's really interesting, and this is really not me. I know almost nothing about these topics, right? I'm just sort of dipping my toe in it. So I can't like a very good, strong historical argument for this, but I can speak as a practitioner, as someone who's been working in Central America for more than 2 years. That is, in fact, the way we thought and talked about child growth. We did this. We really did believe that Maya children were short because they were Maya. We really did. And so then suddenly, in 2006, the World Health Organization's multi-center growth cohort study is published. This was published. It started in 1997. It was about 6 or 7 years data collection. And this is a really remarkable piece of science for those of you who aren't familiar with it. Essentially, there are these 1, 2, 3, 4, 5, 6 country sites. Although I would say like 40% of this cohort is from Delhi, but 6 country sites. And essentially, they did the thing that needed to be done, which is that they enrolled children prospectively. They excluded any children who are at risk of not having optimal development based on sort of contemporary science of what we think about child development. Meaning, for example, children who are formula fed were not allowed to be in this cohort study, right? Or whose mother smoked. Twins weren't allowed to be in the study, low birth weight, like all of the things that you think of as potentially impacting or co-varying with the attainment of child height and child weight were not allowed to be in the study. This is really truly a prospective best of all possible worlds scenario for child growth, and it's absolutely utterly remarkable. This is the length over the first couple of years of life for these 6 different country sites, and I think the point is that all of these children, all of them grew exactly the same, all of them. And this is absolutely remarkable. And really, all of a sudden, it no longer became possible in pediatrics to say children's growth is based on who they are. It became inevitably impossible to anything other than that children's growth is based entirely on where they happen to have the misfortune of being born and grow up, right? And if children, if we can, in all of these diverse geographic and ethnic contexts, we can select a population of children who grow exactly the same, meaning exclude all of the variables that might impede their growth and development. They all just do wonderfully. Right? And this is really a remarkable piece of scientific activism, although I think it was really intended as that when it was done. It was just intended as an attempt to have a modern set of growth curves, But suddenly it became very, very clear that there really was no such thing as a biological shortness, at least the first few years of life. And so for all of us in pediatrics, this was an amazing and revolutionary thing. And all of a sudden, all of us, for example, in the Ministry of Health in Guatemala, could no longer say, we're not short, we're just Guatemalan. So everything changed. It really did. Everything changed 10 years ago, and you don't hear these sort of racist, biological arguments about how children can grow anywhere in the world, almost anywhere in the world. And I think this is really a remarkable achievement. So how is why take us until eventually 2010 to come to the conclusion in global pediatrics? Right? So I think this is the point that I've been really thinking about hard over the last few years, and I wanted to just show you some other data. Because it turns out that lots of people knew this, and the overall reaction to the publication of the World Health Organization's code study on people who are not pediatricians or global health practitioners, among anthropologists and demographers, was basically a lot of heavy eye rolling and heavy sighing. Everyone knew this. Everyone outside of medicine knew that it was basically a social function. That if children or adults' overall height potential was really an integrated function of their exposure to risk. And then if you could account for risk, then they grew better. And anthropologists knew this, and demographers knew this, so why didn't we? Right? And to have a fancy big World Health Organization study to know this, or to rediscover this fact. So the answer is that we've become, in global pediatrics, increasingly isolated from other disciplines. And this is one of the things that I want to try to fix for myself and fix for people who are training. And so this is kind of like where some of this comes from. So I had a trainee who I was going to something about pediatric growth. What literatures could I expose them to so that they wouldn't be like I was when this was sort of just a total revelation to me 10 years ago. So folks have been studying growth in adults and in children for many, many, many centuries. And there's very rich data, especially from Europe, but also data from the 1800s that was a little bit more global in the United States and in the UK, populations, older populations. And Tanner, of course, is famous. Tanner, this is where the Tanner stages, the studies of puberty and adolescent transition come from. But sort of after Tanner, global pediatrics, or as an academic discipline, and demography and public health diverged massively. And sort of after the Second World War, pediatricians stopped reading the demography literature and stopped interacting with biological anthropologists. Or maybe it's to say that biological anthropology sort of emerged as its own discipline and went off on its own direction with its own interests, and pediatricians went off in their own direction. But the point is that after sort of a medical synthesis like Tanner, in which Tanner summarizes all sorts of amazing data from demography studies in Europe and from studies examines the secular trend in height, all of these really important things. If you were a pediatrician training in the 1950s, you would have read Tanner, but if you were a pediatrician training in the 1970s, you would not have. Now we in pediatrics only read, journal articles. Have their own essential built-in amnesia, right? Because the turnover is so fast and the volume is so high. So it's quite common now for those of us who work in pediatric growth and nutrition just to never read any of this stuff ever. So, and I said the growth charts were met with a lot of eye rolling by anthropologists and demographers because that all children grow the same if given access to good resources and food is a way of saying that there's a secular trend in height, which has been being studied for hundreds of years, right? And this is a great article by Merritt, 1973, that summarizes a lot of secular trend data from the 1800s and the 1900s. But just to sort of point out that we know as most societies, both in Europe, in the United States, Australia, also Japan, as these societies industrialize and improve the efficiency of their food systems and their healthcare delivery systems, that height increased a lot in all these populations. For example, here's Norwegian data, 40-year difference in height. This is for females. So mean height goes from 161 to 166 centimeters. Again, about an 8 or 9 centimeter difference in Japan. 70 years. Here we see a little bit less in the United States, but nevertheless, you see everywhere in the world height goes up as access to food and access to healthcare and other things, of course, in pursuit. Here, this is from a nice review article by Barry Bogan, but this is data on Swedish females, just showing this is the mean height of Swedish females as they go through adolescence and into early adulthood. And you can see from 1883 to 1999 that there's a really enormous jump here in overall height potential. And of course, also this is menarche. So as populations get more nourished, menarche also goes down pretty significantly. But that's a side point. So why that, or how can we, as practitioners, rediscover our links to this kind of literature so that we're not taken by surprise when suddenly we rediscover a concept that other people have known about for a long time? I'm thinking about the secular trend in height is, and maybe this is more relevant to those of us in global health, is think about this thing that I sort of call the secular anti-trend. This is not really a thing, I just made it up. But this is another graph from that really beautiful website of height data from around the world, and this is a graph representing change in height in centimeters from 1896 to 1996 in different countries in the world. And so the point is to show, so it's darker means the adult height has changed a lot for women. The point here is to show that there's Japan, for example, there's Mexico. The point is to show that height has changed a lot for a lot of populations in the world, but there are places in the world where height has changed almost not at all, right? And so obvious, it's like here, like the United States had already very significantly into demographic and secular demographic transition at the end of the 1800s, so that's not so surprising. But look at this, I'm going to just go back to where I work, right? So here's Guatemala, here's Mexico, both are similar ethnically and in terms of food system and lifeways and all this. And Mexico had a massive change in its adult height over the last 100 years, and Guatemala has that change in population of its adult height. So again, if we engage demography a little bit better in our practice, it's almost like these sort of like 100-year trends are a proxy for other things that we care about, like social inequality or progress of health systems. Like maybe you don't need the Gini coefficient, or maybe this is an additive or additional analysis that helps those sorts of things. Like change in adult height over 100 years maps pretty well to where things are not working very well. And look at this. I mean, this is like the secular anti-trend. Like what happens when societies regress and go convulse under, overwhelming disease epidemics or under genocide and civil war. This is a female population. Height decline. And go through these. So this is meaningful to me, right? So I'm only discovering this in the last few years that I learn a lot about the places that I work in the world, and I can provide a lot of additional insight to my students if I show this kind of data, right? This is super fun. This is bone data. This is like extremely noisy, and bone data is difficult because the skeletons that tend to get preserved in archaeological digs tend to be the skeletons of rich people, like kings and queens, those sorts of things. So you take all of this with a little bit of grain of salt. But again, this is from Bogan. Again, Barry Bogan, very famous biological anthropologist. Some of you may know. And this is data from archaeological sites in Latin America, all sort of grouped together in a sort of really messy way. This is men, this is women, and so these are bone heights. You can see an enormous amount of noise. But what's really remarkable here, let's just look at the triangles with female data. This is the arrival of the Spanish here, and look how dramatically available skeletal length. I'm sorry. What did I do? Oh wow, that was a lot. Look, skeleton height declined for women in the several hundred years after the arrival of the Spanish. It's really incredible. And then all of the countries in Latin America, as you know, achieve independence sort of right around here, and height starts to go back. But there are spasms, like in here, there's a lot of civil war in here, and so, but anyway, sort of an interesting, messy but holistic view of it. A similar example, this is just from Guatemala. I apologize, I only have this in Spanish. These are the skeletal lengths for pre-classic, classic, post-classic, and colonial skeletons from archaeological digs, and these are modern Maya skeletons. Really remarkable, right? The difference in height here to here. And then, of course, the last several decades, height starts to improve again. really remarkable to say, there's almost like a colonial illness, the Spanish arrived and declined, 50 meters. It's absolutely incredible. So if we had just looked at the demographic data, we probably would have known about this all along, right? I guess that's one of the points here. Because the fact that children grow the same if they're given access to resources is another way of saying what demographers have been saying for a long time when they talk about secular trend. And logical anthropologists have known about this too. For these 3 or 4 decades now, a study of migration of populations. So this is, there are good examples of this too from like Japanese immigrants to the United States, but I give a more specific example that involves an indigenous population, because part of the reasoning here of the argument is that like indigenous people are short, racially short, right? And so this I think is particularly helpful. So this is Barry Bogan, who studied Maya populations in different places in the world, including in Mérida, with the Yucatan, which is a relatively more affluent, stable Maya population with good access to public health, food. This is Guatemala. This is all done in the 1970s and 1980s. This is recent data. Guatemala, and then this is an out-migrated population living in southern Florida. And so it's utterly remarkable, right? So this is height. This is ignore resting leg length, relative leg length, which I think is less interesting. But there's a change in height between these 3 sites. And if you look at this and this and this, Guatemala, southern Florida, change in height, attained height for these children is absolutely remarkable. So this is the environmental access to different resources. Right? This is we were involved a few years ago. We took pictures of a group of 9-year-old Maya kids in a rural Guatemala community. We took a picture of 9-year-old kids in Florida. This blue line, which you can't see very well above their head, this is the 50th percentile for height, and this is the 50th percentile for height. All of these children are sort of from the same ethnic and linguistic background, and the only difference is that one's Florida and these are born in Guatemala. So I think a picture is worth many words here in this case. So the question here, the open question is: if we had been aware of the other literature that existed at the periphery of our conscious, could have gotten to this place sooner, and that have made a difference for global practice? So that's the question. I don't have an answer, but that's the first question. The second question is, now we have these new WHO growth. There's in the last, really just last 5 or 6 years, there's a new global consensus around what stunting is and what we should be doing with it. And this can be summarized really in 2 key messages. The first is the first 1,000 days of life, that we have to test all of our resources and all of our ammunition before children turn 2 years of age, because after 2 years of age, the boat. And you can't fix anymore, and everything, all the bad things happen, right? So that's the idea of the first 1,000 days of life. It's a good idea, because we all know intuitively that early investments pay off. That's the case whether you're talking about your retirement savings account or young children. The major consensus, and this is new, right, is this idea of nurturing care. This is just based on this Lancet series, which just was published last year, which revisited the data on child growth and early child development. And there's this cute graphic which is being workshopped right now. There's like doing consultations right now. I don't know, some of you may be involved in some of the UNICEF, WHO consultations. The idea is this is nurturing care. And of course, this is really, really revolutionary, because the idea is that children, if they get to eat and get access to health care and have parents who care about them and have access to education, do better than if they don't. Very revolutionary concept, right? But the point is that, these like no-nonsense, of course, ideas get codified into social policy that's propagated to ministries of health around the world, and this is the one for stunting, right? So the reason to bring this to your attention is because I sort of talked very briefly about how stunting emerges and how we maybe didn't realize its differential effects on children because we weren't aware of existing literature. I think a really important concept when talking to trainees is now when you have a new global consensus like this is a new global consensus, how in addition continue to maintain a critical stance toward it. Because consensus like this leaves behind as many things as it puts forward, right? I want to just point out to a few of the things. First point is, if we engage with the literature, potentially we can be more aware of supporting evidence that can make our actions more effective. The second is the data that's used, the inputs that go into these sort of statements, the consensus paradigms, we can be aware and we can teach our students that they leave behind, because some of the things they leave behind are really important. This is part of magical thinking, right? That success in child growth and nutrition is how we ignore assumptions and the compromises that lead to these consensus. So I just want to you about a couple of these. One of them, the most important one, is that the global consensus on stunting has totally ignored all the data about catch-up growth. Right? If you talk to a frontline practitioner about the 1,000 days of life, they will tell you that what the 1,000 days of life means is that children grow until they're 2 years of age, and after 2 years of age, they don't grow anymore. I mean, they obviously grow, but their growth velocity is fixed, and whatever they lose before 2 years of age is totally gone forever. It can never be recovered. Right? And so this is very important because it has led to a molecular focus on prevention. Right? If you go to your average standard Ministry of Health program, all of their stunting work will be around preventing stunting. And this does not play very well in a country like Guatemala, where 90% of the children are stunted. So you're saying you would just abandon the entire current generation of children because we can't do anything for you once you're not growing well, right? We can only prevent from growing badly, but once you're growing badly, by a but you know, it's really ironic because several of the most important cohort studies that went into building the 1,000 days consensus that shows that investments have a big impact on growth. Also, the cohort studies that showed that children grow after 2 years of age too. So the South Africa and Guatemala cohorts in particular are fundamental to the data analysis that went into developing the 1,000 days concept. But both of those cohorts have very robust demonstrations that growth catch-uppers after 2 years of age. But this little piece of data has been completely ignored in the development of the consensus statement, presumably because it's complicated, presumably because it makes program development a little bit more tricky, because all of a sudden you can't just have one focus on one thing. But it's important, especially for those of us who are working in places where there are lots of malnourished kids. So I diverted attention from this pragmatic argument, right, which is that we should invest money early. Of course we should. But who's behind when we make those kinds of statements? This is a thing I think that probably happened that really put folks in this direction is the Heckman curve. You know, James Heckman is Nobel laureate, who's sort of made his career by analyzing early child development and their long-term outcomes in adult populations in the United States and in Europe. Has this thing called the Heckman equation, or Heckman curve, which basically, I know some numbers behind this, but the power of a graphic, right? That if you're early, you know, show better. So you take the Nobel laureate who's extremely active in the scientific and in World Bank kind of sphere. Take this kind of messaging and you combine it with cohort data from the World Health Organization, and this is where this new consensus comes from. But again, this is, again, to repeat myself, because I don't have one point here. For the people who have been the most upset about the 1,000 Days Initiative concept have been, in fact, demographers and biological anthropologists, who know this is not true, that humans lost a lifespan, and there are many opportunities to intervene and to foster growth, and that focusing on children under 2 years of age leaves a lot of people behind. And this is height for age Z-score trends for female populations. I can't remember where I pulled this from, what cohort I pulled this from, but the point in particular, one point here in particular, is that children grow when they're teenagers, a lot. They grow a lot. And so in a lot of ways, the 1,000 Days Initiative remembers the plight of 2-year-olds by forgetting the plight of teenagers. Right? It's like critical. It's sort of a zero-sum game here. It doesn't have to be, but it's a zero-sum game if we're not aware of compromises we're making when we make these very broad statements. Right? And this is absolutely critical. I'm just going to read one quote to you from a good friend of mine, Alejandro Colon, who is the country director for Population Council in Guatemala. And this is about the impact of the 1,000 Days initiatives on adolescent pregnancy in Guatemala. But I think it's fully applicable and makes the point that I want to make, which is the 1,000 initiative, with its emphasis on chronic infant malnutrition, adolescent females are relevant to society only when they become pregnant. After dropping out of public education in early childhood, which is almost a statistical inevitability for a girl from a rural community, this child falls out of the public eye. She does not have access to educational opportunities, enrichment activities, or social outlets. Indeed, she becomes visible and visible again only by becoming pregnant. In other words, by once again becoming a subject of the 1,000 Days consensus. Right? Focus all of our societal efforts on pregnancy management and child malnutrition prevention, in the absence of also developing adequate sexual rights programs for young women, is akin to planning for poverty. So this is an really critical reflection on the impact that the off-target impact of the 1,000 Days initiative on other populations, which really is another population of children, right? In this case, right? Some pregnancy being extremely common in Guatemala and elsewhere in the world. So let's forget about the things we forget, we leave behind when we make these statements, and let's try to teach ourselves and teach our students where compromises lie and who gets benefited and who gets left behind. Another point about these sort of policy statements and how they shape our thinking, anchor us on certain concepts to the detriment of others, is that I think that they lead to an emphasis on short-term gains, which is important for generating political will and action, but is also discouraging and ultimately pretty misleading, especially in the case of stunting. So you all have seen some of these analyses of the effect size of stunting interventions, right? They move the population Z-score like 0.1 or 0.2 standard deviation. They're very small, almost, they're statistically significant. They're very small. They're often clinically irrelevant changes in height. Right? In other words, you don't necessarily see any outcome in terms of health of the child. There's probably some long-term outcomes in terms of development or economic potential as an adult, but those things are not measurable over the span of time that parents care about, communities care about. So these are very trivial, clinically very trivial outcomes. And focus slowly on them, it can be extremely discouraging, right? And this is another one of the immediate effects of taking complicated data and turning it into small little policy tidbits like nurturing or like the 1,000 Days initiative, because suddenly we're going to have a 10-year target here, a 10-year target or a 20-year target, and we're going to be measuring statistically significant but potentially clinically irrelevant changes in the health of child population, saying that these don't have an ultimate long-term benefit for human health, for school attainment, for things that matter, but there's things that are really hard to play in community when you're committed to grassroots action. Right? And a final thing that they do, that these sort of policy consensus are, the final effect that they're having on the field growth in particular right now, is allowing us to sort of ignore the limits of biological plasticity. And again, you're really focused on short-term gains and child outcomes, and you have very small effect sizes. It's easy to get discouraged. But there's an alternative explanation to why effect sizes in child growth are so small. And if you were a demographer or a chemist or a bioanthropologist, you would know this. But we as pediatricians don't know this. And the reason is that there's like a limit to how much a single can change. I'm not being Lamarckian here, but we can't just suddenly shoot up like weeds, right? And there's interesting data. It's sort of scattered around the literature in articles I want to read. But there's interesting data on, for example, the ways that the metabolism of stunted children is different than the metabolism of non-stunted children. This is one example from a study done in Brazil where a lot of this data has come from, looking at the respiratory quotient. This is a fasting and then postprandial respiratory quotient in stunted children and in a control population, non-stunted population, just to show you that the respiratory quotient is much lower in population, which means that they are better at metabolizing fat. So stunted children and adults who were stunted as children actually have this sort of like insulin resistance metabolic syndrome phenotype. They have it. The problem is that most of this literature is buried in the exercise physiology or like nutrition lab science literature. And again, that literature is not accessible to or by clinicians. But there's a fundamental intra-subject limitation to how much growth you can subject a child to before they get obese, or before they get diabetes, or before they develop blood pressure. And so populations know this in the sort of like physiological sense. And so there's only so much height that can be achieved with a single generation. Again, demographers and economists have known this forever. So this is really interesting that I don't understand that I've been reading recently. There's this interesting body of literature about the calorie price income elasticity of demand paradox in the 17 and 1800s, which is basically the idea that these are some calories, daily calories for this working population in England and Wales in the 1700s. And just the point here is, let's just look at this column here. The point here is to show you that they consumed very little calories. I mean, maybe 3,300 calories in 1850 sounds a lot like you. You're a coal miner. I assure you that 3,300 calories is not very many calories. So they make this point that in populations in the 1700s in Europe, calories were not sufficient to like sustain a good quality of life for laboring populations, and yet income was rising. And you look at consumption of products, say like food products and calories in England and UK over this time period, the income elasticity of demand is well below what you expect for the food products. In other words, you expect that as income goes up, if a population is relatively calorie deficient, they will eat more food, but they don't. And this is sort of an interesting paradox that's been argued about for about the last 50 or 75 years in the economics literature. You would expect that this income elasticity would be more like 0.6, 0.7, which is how most normal goods behave, meaning if you have money, you buy more. The elasticity is just the ratio of consumption to income. But in fact, in fact, they're very close to 1, which means they almost don't behave like goods at all, these calories. In other words, income's up, but people don't spend it on food, even if they don't have enough food or they're not getting enough food. The point is that this is a circumstantial but a telling argument that the reason that people don't eat more calories is because their biology wouldn't permit them to utilize those calories. And like a classic example here is if you have environmental enteropathy from exposure to pathogens and you have chronic diarrhea, you could eat more calories, but you'll just poop them out. Areas, right? And so populations, on average, don't increase their calorie consumption to the same degree that their income increases. This is another way of saying that there are limits to the biology and the limits to the amount of height that we can attain. But for the most part, in the way we talk about how we're going to transform child nutrition and transform the health of adult population, the height of adult populations over the next whatever the SCG timeline is going to be, right? So where am I going with all this? I don't really, like I said, it's just brown baggy, right? So you have to suffer through it. But I do know the answer to this question. I know the answer to the question of all of this is the case if have played to the game and have allowed racial theories like discredited hundreds of years of racial theories of growth to influence our practice almost to the present day. And if we constantly get sidetracked by simplified policy statements that leave many children behind as they carry forward, and if we ignore literature and have an over-optimistic view of the impact that we're going to have on health of populations, how then do we fix stunting? Right? That's really the question. So you know the answer to that. This is the answer. We're developing a 120-year transgenerational roadmap for sustained societal transformation. So we can't fix this problem in our generation. We cannot do it. And I'm not advocating that we say that to donors. We need a space to say this. And this is missing in this field. We need a space where, I don't know, among colleagues or trainees, we need to be able to say this. We need to be able to develop a professional psychology that allows us to say that we're committed to a 100-year problem, right? Here's our trend, right? This is Sweden, France, Netherlands, 800 to 1920. The life of this population doesn't start to top out until 120 years into this problem. This is a 6th-generation problem, right? And everywhere we're working in the world, it's going to be a multi-generational problem. In a lot of ways, despite our focus on immediate gains in child growth and nutrition, I say to myself, where is my commitment to this? How am I helping the society I work in to develop a multi-generational or a transgenerational plan? How am I thinking about what this is going to, we need to now to sustain our activities 50, 75 years from now? I don't know, but I know the answer to how to do that, but I know that that is the answer, at least to the problem, to the problem extensive. So I'll give you with a prediction. You know, the theme talk for me is all about like how there's stuff out there that we just don't know about, and so we forgot it, are never aware of it, and then it comes back to us and we experience it as a renaissance or a rediscovery. Then someone will roll their eyes and say, if you just read broadly or you just interacted with colleagues outside of your field, you would know this already. So here's a prediction. The prediction is that in the next 10 years, global health is going to rediscover that stunting is the major risk factor for adult non-communicable chronic disease. It's out in the literature, and we'll all ignore it. If you read like the series, for example, on nurturing growth, there will be one sentence that says there's some evidence that maybe people with stunts go on to have hypertension or go on to have diabetes. This is a very robust literature, both in clinical nutrition literature that no one reads, and in demography literature. So these are Whaler curves, Whaler, 1984. These are Whaler curves looking at the relative mortality as a function of body height. And this is like absolutely incredible data. Military data here is really incredible. This is our data looking at recruiters rejected people from enlistment in the Army based on their height, because they knew, and this is versions of public health, right? You know, in the United States, post-Civil War, and during the Civil War, if no one else did, they knew that if you were short, all the bad things came along with that. Right? So we know this stuff. Demographers know this stuff. Practitioners are going to rediscover it soon. Right? Discover soon that there's a very strong link between non-communicable chronic diseases, diabetes, hypertension, abdominal obesity, and the metabolic syndrome in adults, in stunting in children. And stunted children are the ones to go on to develop these things. I think so. That's all. I think I talked too long, so I'll stop there. And hopefully it's interesting, and hopefully there, I don't know, some commentary or criticism. This is me sort of being around in this space, trying to discover and develop a more reflective practice. So it may or may not be cool, but I'm hoping it will provoke some commentary. Thank you.
So thanks, Peter. We have time for questions.
I've got it up so I can hear it.
So, I'm really fascinated, partly because I've been working with this for a long time. And one of the things that is really interesting to me is sort of where this disconnect between other disciplines and medicine happen. Because you're saying what, only in the last 10, 15 years. I was worked with Food and Agriculture Organization from 1991 to 2000. So I was working in their communications and information division. And around the International Conference on Nutrition in 1992, and then the World Food Summit in 1996. We were desperately to push this message, and we were talking about stunting very as the sort of key indicator of nutrition and hunger, and all of the ramifications it had to life, referring to the bar hypothesis about like we were talking about at the end, tend to increase risk for non-communicable disease and health. And talking about how it wasn't regularly or genetically based, at the time. I mean, I think perhaps, in fact, the cohort study sort of came out as a done to sort of risk the evidence what we did at that time. What did populations that go other places where there's more access to food, better health care, better sense of water, all of these things that contribute that, lo and behold, the height curve pretty much, as you showed, comes identical. So it's interesting to me that was, well before the time you're talking about, and it was, on the agenda and the radar, and where the disconnect happened, or how, what we were trying to do was to reconnect, I guess, and didn't have much. Yeah. But I'm curious to understand that better. The other thing that struck me is a couple of other things. One is you saw going on this focus on, there's all tendency, I think, particularly when looking at poor populations, to focus on let's aim at prevention, because actually dealing with the long-term consequences of treatment is always going to be more expensive, and it's too much, you can't deal with that. And I think, as you know, that seems to be where we wound up. Focused on the first 1,000 days. Yeah. Really sort of walking in on that focus. The other point is that, looking sort of beyond the, to the later social economic planning. The guy who was the co-chair of the International Council on Nutrition in '92 was really fascinating. Indian guy named Michael Berkeley, Swami, who's a nutrition. He sort of advocated and wrote a really powerful article that I refer to all the time, looking at what he referred to as the Asian paradox, which was that something is so much more pronounced in South Asia and India in particular than in Africa, even though poverty was perhaps probably worse in Africa. Yeah. And his case was his major reason for that was gender discrimination and the question of women. Yeah. And that translates both into the 1,000 days, in a sense, why women themselves undernourished, and that is birthplace and so on, but also they're not being empowered and having access to resources to feed their children. It's not that they're too gluttonous with the nutritious diet for the children, because they're both poor and they're disempowered. Yeah.
I don't know where the disconnect comes from. I think that's like one of the things we need to figure out. I think we all need to figure out how, at least to better, as we interact with new trainees, how do we help fix this, in some way, either by encouraging different types of reading practices or developing groups that are more intentionally multidisciplinary. I don't know. I mean, at the development policy level, though, that's another thing. One of the two other thoughts I have are just conjecture. That there's been a very needed and important focus on acute infectious diseases in global health over the last several decades, and that was important and obviously has been remarkable. So maybe some of this is sort of like, you kick yourself for something that's actionable then, you can't really act on something if you're trying to figure out about HIV, for example, right? And so maybe this is just a new opportunity, and so now retrospectively it looks worse. That's one thing. I don't know. It feels like the culture, the development culture is like necessarily contributes to this. There's just somewhere in the multilateral organizations. Everyone is like doing a country mission stint for 2 years, and like they come in, all the documents are in a file cabinet, or they didn't get the report done before the last person left, and so it's like constantly there's a total institutional amnesia in USAID, World Bank, at country level, right? At least all the people are supposedly looking at, just as if they were starting brand new, right? And so every 2, 3, 4, 5, like that movie, that Bill Murray movie, And so I think that has to contribute to it too, the way we've developed this sort of professional rotating expatriate culture in these big development organizations. That must have some effect, where these huge policy initiatives just disappear. I don't know.
Well, I don't know, my question is that as long as we're talking about interdisciplinary stuff, like I can help but think of the ecology on how those bodies are. It's not
No, please tell us. Yeah.
Well, I don't actually know it that well. Basically, the idea is that and just sort of energy forms are a lot of biological. So, striking patterns in body size of lots of organs in the world, according to like latitude. And they outside a lot of these kind of fundamental issues of how we have lives. Now, I'm bringing it up just because you're emphasizing a lot of like what's the broader literature today about these kinds of issues, and of course there's other organ standards humans that have body sizes and have patterns around them. But I've been thinking about how that maps on the sort of like story that you're telling, and I think one other story, like which is that height is largely driven by fundamental physical things that have a lot of temperature and latitude, stuff like that actually do affect how to survive for the planet. And it may not be relevant actually to the story when you have other ways of surviving in certain temperatures or whatever, but it would, because those patterns are so striking, because they apply to like grazers and moose and like earthworms. It's like worth being aware of, I think. It's like fascinating.
I agree that I basically just feel totally overwhelmed by this stuff, because this is this new, like I said, development project that Aaron is pushing into. Like the minute you just get into this, it's just totally overwhelming. I mostly feel like there's so many literatures here, but together I can develop. The thing that's really interesting about this, again, like talking about the literatures that we ignore, about the world growth cohort stuff, it's also not actually true that all children grow the same. Also, a simplification. Like look at DHS data sets, and you put them, for example, by economic status. Every country has a plateau, like so, where you're like these are sort of like economic quintiles like this. Every country, and this is height for age score. Every country has like some plateau at some economic level below which height no longer decreases. Every country does. So you see, it looks something like this, right? And this inflection point is sort of like, and then it doesn't matter how poor you get below that, your height doesn't get lower. This is the case in every country in the world, and this is different. So it's not totally true to say that there is no difference in the population height of different populations. Of course there is. We're not all exactly the same. But I think it's probably like relatively trivial. I mean, we're just talking about a couple centimeters here, compared to how much height children lose when they don't have access to resources. But even in like this, again, it's another theme. That willfully ignores data, and this is another piece of the data that was willfully in the DHS WHO cohort statement. So, like Tanzania, that population is very tall. They really are. Their plateau is something like 2.5 centimeters higher than the World Health Organization standard. You can make the point that if you use the World Health Organization cohort and the need to underdiagnose these because they're stuck higher at higher stroke.
Is there a history of stunting as a concept, as a history of the correlations that are made between stunting and other chronic disease over the past 100 years, or maybe, or the uses to which it's been put?
I'm not aware of anything. I mean, most of the demography is all about adult height, almost about adult height, and then there's some boarding school studies, and there's studies of adolescents. Those are the studies that I'm aware of, where the shortness is analyzed. But and then I'm not really aware of even stunting as a concept existing in the literature, except in the last 30 years or so.
Because a developmental concept.
The concept is
something that's not static,
right,
as opposed to the artifacts that are being used by the people who are researching demographics.
Yeah, I'm trying to think back
and
to
it's defined by growth curves, which are sort of like a post-World War II thing. So.
Right, that's right. So I've seen, these early in-cap stories where there's a lot of focus on height and weight, but I don't know the notion of something per se.
And there's very little like interaction with standards or growth reference set in the literature. They're looking at overall, and then there'll be some sort of random thing like that graph I showed where like, oh, this is the height of a population of children in, this is the height of a population of children in Guatemala. There's very little norming.
So much you can try to actually go with the
Yeah.
history of these, as far as you think about the weight given to biology, to something per se, might be how that detrimental.
I agree. That's like one of the things I'm hoping to do. I'm just about 500 books shy.
I mean,
there, but
one of the places you would look is this kind of history of childhood, which is fairly robust, I think, over the last 30 years, and would be somewhere where you might be able to see some of that. I invest 70 years. No. Yeah.
And I'm very aware that stuff exists, and I haven't looked at any of that. This whole pile of like theory literature to look at, and I'm fairly familiar with the anthropology stuff, which doesn't really get to this either. So really talking about the development of professional pediatrics in professional nutrition science in the last 100 years, and where this, and I haven't gotten to that stuff at all yet, but I know it's out there.
I think it's a global malnutrition, places like the example.
Yeah.
One of the things you're grappling with is a concept of disciplinary stunting. What the kind of conditions that that promote the focus on particular metrics that are nutritious might be, and how you can avoid this malady. That seems like potentially just as a kind of meditation, it might be fruitful.
Yeah, and that's actually the thing I'm most. That's what I'm most interested in. I'm not writing a revolutionary disciplinary textbook on the history of stunting. It's not going to happen. But what I'd like to do is to have of interact with new professionals, young professionals, that's more reflective than the way I came up with it. I think that is achievable. And obviously, I do all this work in nutrition, so I'm sort of stuck there. And it's nice because it's not just physicians, but there are a lot of allied disciplines that are stuck in the same quagmire because nutrition is interdisciplinary stuff. But it's not just, I mean, we do this in WASHs are similarly sort of mired in colonial ideas about how to reorganize indigenous populations. And, I feel like there's a lot of places, a lot of them that I'm just poking around blindly now, trying to sort some things out. And as an immediate sort of fruit of this, 6 months or so that I've spent doing this reading, is I feel like I'm much better prepared to talk about this topic with and give them a nice crash course in stunting, at least. But obviously that there are these broader questions about where does content come from, and how has new science in general evolved, and how does that fit into theories of childhood. And this is, I think, all things that need to be addressed. So, I'm going to keep.
Okay,
Thank you.
Yeah, you did well. You did well. What was the title of the book? Oh, Disciplinary.
Disciplinary setting. Thank you.
Oh, God.
So, are you jetting off again? Like legitimately in future, or are you around?
I'm around until the beginning of January.
Okay. Do you want to see if we can find time to think about this?
Yeah.
Because I think I'd like to push it a little bit.
I mean, I made some progress, right?
Made a lot of progress.
Yeah.
I thought this was great.
It's just overwhelming once you get into it, you know. But
It's kind of really like an experience.
yeah.